All right, so we're first going to hear from Dr. Merchant. Dr. Merchant is a movement disorder neurologist with clinical and research expertise in invasive and non-invasive brain stimulation treatments for movement disorders. His clinical practice has a special focus on movement disorders, and he uses the latest technological advances for the diagnosis and treatment of several movement disorders such as Parkinson's disease, tremors, dystonia, etc.
I'm going to talk about the clinical aspects of movement disorders. Dr. Aronson is here, which is fantastic, and he's going to talk a little bit about the technicalities of the surgical procedure itself. So Second, okay. I have one conflict to discuss. As I was talking to some of you guys, I served as the advisory board for Medtronic recently, which was basically held at the movement disorder meeting to discuss about our experiences with the new adaptive stimulation and learning about how could we develop the technology. So they had asked me to help with giving my opinion. So that's the only conflict of interest I have. This is a typical picture which is there for deep brain stimulation. This is how it looks like, apart from the fact that nothing that you see in terms of the hardware is sticking out. Everything is under the skull. Everything is internalized. All the wires and stuff is all under the skin. But essentially, the hardware is essentially looks like that. What you see in the screen here is there are these two burr holes through which the surgeon puts the electrodes in very precisely located, using a very good localization and putting it in very tiny nuclei where we stimulate the brain to improve some of the motor symptoms associated with different movement disorders. Uh, so this is what are the factors for successful DBS. First of all, the most important thing is appropriately selecting the right patients. I always like to emphasize that DBS is not a therapy where everything else fails and everything else has not worked. There is always a place and time, and introducing a therapy can be specific to a patient. It can be a great treatment very early in the disease. It can be a treatment later down the road. So every patient, making that decision and defining the goals is very important. Second thing I always emphasize is to have reasonable expectations in terms of what do you need to achieve, how is this going to enhance your quality of life, and how is it going to be significantly better than what your treatments are controlled based on medications. So we always have to weigh the risks and the benefits. If the upside is so good that it's going to be a great treatment, that's when we want to proceed with this. But at the same time, defining that upside is actually even more important as to what do you mean by improvement. Second thing is accurate electrode placements. We have two excellent surgeons in Dr. Aronson and Dr. Alterman who are very experienced, and that is a very critical part of this treatment being successful. So that is a very important aspect of deep brain stimulation success. After the placement, it's about careful programming, understanding the location of the leads, and having the nuance so that you can continue to get benefits for longest period of time with this therapy is very important aspect. And long-term follow-up and having a plan in terms of adjusting your stimulation, adjusting your medications, and modifying it as the disease changes over time. Realistic expectations. DBS is a symptomatic treatment. That means it treats the symptoms of what you may have, which may be in Parkinson's disease, the symptoms of Parkinson's disease, such as tremors, mobility problems, stiffness, tightness, as well as dependence on high doses of medications and fluctuations. In tremor disorders, there is an improvement in the tremor. So it treats the symptoms. It does not. So once you have a DBS surgery, that it's actually an ongoing treatment that you're getting to improve the symptoms, and it is not a cure. It does not, there's no evidence at this point, at least that we know of, that it slows down the progression of the disease or has any impact in how the disease would go, or what your disease trajectory would be, whether you had the surgery or without the surgery. So it does not have any impact on the progression of the disease. Uh, it takes time sometimes for certain symptoms to achieve the best results. It takes a little bit of intuitive programming over time to kind of balance your medications and treatment for like disorders like Parkinson's disease. specifically disorders with Parkinson's as well as otherwise. The problem of dystonia specifically is a problem which kind of is not an immediate effect, but we have to wait and be patient and you program these patients because the benefits can lag after the changes are made to the stimulation. For Parkinson's disease, DBS responds as well, and even the symptoms that respond are as well, or even better at the best benefit that you get in terms of your mobility and other symptoms with your doses of Parkinson medications, whether it be levodopa or any other type of dopamine medications. Discontinuation of medications is a goal in some disorders. For instance, in disorders like essential tremor, in disorders like dystonia, where the medications are anyways not very effective at some point for controlling those symptoms. For Parkinson's disease as well, we for tremor dominant, where tremor is the most bothersome symptom, I've had several patients who are not taking any of the Parkinson's disease medications anymore, but that is not the primary goal of this treatment. A lot of the times you're able to drop the doses of the medications. You don't have the need to take the medications as frequently or after very short periods of time and have to worry about the medication effects wearing off. So those are all the benefits of it. So you can come down, especially with one of the targets we use in Parkinson's disease called subthalamic nuclear stimulation. You can get a significant reduction in your requirements for medications with the surgery. What are the symptoms that most likely to respond or improve with DBS? In Parkinson's disease, the tremor responds exquisitely well, and as a matter of fact, in about a third of the patients, or about 30% of the patients with Parkinson's disease, the tremor is not responsive to levodopa. So in that case, you have to have this careful conversation with your physician that you're incrementally increasing the doses of the dopamine medications, which can now cause you to be more having both motor side effects as well as behavioral side effects, and you're not getting any benefit for the tremor. It is one of those times, as I was talking about initially, that this is a very good indication to intervene early with DBS, because you can potentially be on no medications and have an improvement in the tremor, whereas incremental doses of the medications are not responsive. The symptoms don't, the tremor doesn't respond. So medication refractory tremor is a very good indication for pursuing or surgery early in Parkinson's disease if that's the kind of tremor that you have. It improves the stiffness, mobility in terms of the slowness of movements. Again, as I say, the benefit in slowness, the stiffness is going to be as good as you get with the best doses or the best effectiveness of what you see with your levodopa or dopaminergic medication. One other aspect of it is sometimes in Parkinson's, you develop these fluctuations that when you take the medication, you're moving too much. And when your medications are off, you suddenly can't move anymore. So DBS is a very excellent treatment when you develop those complications. Symptoms which does not improve in Parkinson's, if you have a predominant gait and balance problems. If you have this problem called freezing of gait, which means that when you're walking, suddenly your feet start to move in one place and you cannot move any further, or your feet get stuck to the ground. Hallucinations, hypophonia, what you call the softness of voice, as well as difficulty swallowing. Those are usually problems which we do not expect to change with DBS. At the same time, a lot of these problems can worsen with deep brain stimulation as well. So we have to be very careful when we evaluate these patients to decide whether or not they are good candidates. Apart from the fact that these symptoms will not respond, they can also worsen if that's the main problem or the crux of your Parkinson's disease disability. Moving on to essential tremor. Essential tremor is a disorder where people, unfortunately, you might see this, it's very common, but still we don't use it as effectively. And we see a lot of seniors and folks who have this shaking, which is very disabling. They cannot feed themselves, they cannot eat. And a lot of the times, unfortunately, a lot of these elderly seniors who kind of develop these disabling tremors uh, are put on all these medications which are very sedative, and it can have an adverse effect on their mentation and cognition, which is a very under recognized problem. So essential tremor is one of the most effective treatment for that is deep brain stimulation. There is another treatment called ultrasound where there has been some lesioning done for this probably disorder, but the effectiveness, especially when the tremors are really bad, of DBS. There's no other treatment which is as effective as DBS for tremor disorders. things that do not change as far as the tremor. Sometimes the folks who have tremors, they can have balance problems, memory problems, a lot of voice tremors. They don't seem to respond as well. So that should not be, again, a major reason why you want to pursue surgery for tremor disorders. Dystonia is another disorder. Dystonia essentially means there is abnormal and excessive pulling of the muscles or tightening of the muscles. It is a very common problem that happens in Parkinson's disease, but also it can be part of a lot of hereditary disorders, and people just have a dystonia problem wherein there is increased excessive activity of muscles. This also responds very well to deep brain stimulation. Uh, as long the certain types of dystonia, though, that can happen in disorders like after you have a stroke, you can develop a dystonia. Sometimes there are many hereditary disorders and neurodegenerative. That means there is slowly loss of tissue in the brain, and over time, those brain regions are reduced to having no active brain tissue there. So in those are called secondary dystonias, which can develop after strokes, after trauma, after some of these disorders of the brain. And in those regions, that what happens is the areas where we usually put the DBS or the electrodes to stimulate the brain, they are atrophied and they are necrotic. So you can understand that in those type of disorders, the brain stimulation surgery would not be very effective, considering we don't have any alive tissue to stimulate. So those are called secondary dystonias, where we don't like to do these surgeries and does not help much. I'll just talk about our program. The approach that we have in our center is a multidisciplinary approach. So the part of this is, one of us, do you have patients? Do you have your neurologist that several of you have had? Do you have doctor that you see us in the clinical evaluation? Then we have a conversation with you and we decide whether or not you're a good candidate. After we do decide that you could be a potential candidate, we have you see our neurosurgeon. So you see either Dr. Aronson or Dr. Alterman. They do very precise brain imaging and they look at the brain structures very carefully to evaluate whether all the brain regions where they intend to put the electrodes are healthy. What is the health of the brain general, and then they decide. And when they meet you, you go over a conversation about the risks versus the benefits and the effectiveness of this treatment with them, and going over what can be the different plans in which they can implant these electrodes for you. We also see as part of this is neuropsychology. As I mentioned, memory problems are very common in a lot of folks for all the indications that we talked about. So we want to make sure that we have a good understanding of your baseline memory and thinking. We also see a speech pathologist to understand what your speech content as well as the quality of speech is. You see social workers in certain cases for you to understand of all the resources, and to navigate through this process. And also in certain cases, you meet our psychiatrist who kind of go over in case there are a lot of polypharmacy, a lot of medications people are on for mental health issues which can happen with movement disorders. So we sometimes have to gain their expertise to understand if there are any major problems in terms of pursuing this surgery. And with memory problems and problems of behavior, we want to make sure that if we were to put you through all this surgery, you're able to maximize the benefit. You are able to make the decision on your own and decide on the goals of the therapy with your consent and with your understanding. Usually, after the surgery is done, we see you in the clinic in about 3 to 5 weeks' time. That's when we allow enough time for the brain tissue to heal. After the surgery, you see the surgeons in their outpatient clinic. They look at, if there's any complications from it, and all those things are checked out. The first session usually is a little bit longer when we try to evaluate what the lead placement is based on stimulating the brain, the different electrodes in the implant, to understand what would be the most effective way to stimulate the brain. Uh, after after the initial few programming, we initially kind of get you in every few months just to keep a close eye on you when we monitor and make most of the changes. After the initial few programming sessions, most of the patients stabilize and we see them every 3 months, and then progressively every 6 months, based on how you are doing and how confident or how comfortable you are in terms of managing this at home as we walk through the steps. Parameters which we change are amplitude, that means the amount of current which we give, the pulse width as to how wide each pulse width of that amplitude is, and lastly is that how fast we stimulate your brain. Most of the times, and we all of us use a high frequency stimulation. That means 130 hertz and above is usually what most people's practices are, what we use to stimulate the brain. Uh, Follow-up programming occur, as I said, every monthly. Then we can customize the follow-ups based on your comfort level. There are a lot of these advances over time. One of the most interesting advances, I think, has been this what you call is this fractionated lead or directionality, which has come to programming. So as you can imagine, there's red spot is a sour spot. So when we do too much brain stimulation, it can spread to regions of the brain we don't want to stimulate. And then at the same time, you can say this is a sweet spot. We want to stimulate the brain regions and structures which can improve your motor symptoms. So we have to find a nuance and a good balance to kind of stimulate the regions where we improve the symptoms, as well as avoid stimulating the regions which can cause side effects. So using this new directionality, we can kind of create more of an intuitive, and I think all the devices now have this directionality feature to it, which has been, I think, been the most helpful feature so far in terms of the evolution of DBS technology, where we are able to more precisely move the charges and stimulation. This has been the evolution. Initially, there was Medtronic, which was the main one company. Over time, there have been other devices which have come in the market. There are all these different directionalities as features. There is a new technologies where there are higher, more contacts and stuff. But for all practical purposes, the basic principles remain the same. You implant the device at the right spot. You have good team of folks who are programming you. The benefits of the different technologies are similar as long as the implant and the effects are. But I think we are all very excited and we are learning with this new technologies of adaptive stimulation. We don't know how would this how with different field modulation and using image guided programming, how the longer term outcomes can be different. So we are all learning. This is like what the pacemaker which goes in the chest wall looks like. They're all very thin and comfortable to put nowadays. They've gotten more and more sleek over the years. Evolution, again, as I was talking a little bit about it, initially we used to talk about constant voltage stimulation, that we would put a particular voltage and set up a particular programming. Over time, that evolved into constant current stimulation, where now we can deliver the device intuitively delivers the same amount of current as the system resistance changes. That kind of then came the era of segmented stimulation, where now we can precisely modulate the field to kind of get away from the sour spots and stimulate the regions which are going to give you the best benefit. And then there was even more precise. So Boston Scientific came up with this even more precise, that can you change the anode and the cathode intuitively in many different combinations, and each of the sections acts as its own modulator in some ways. Then Medtronic is coming up with some more exciting stuff. Recently, they got approved for this technology called adaptive stimulation, where what they are trying to do with the system is that the electrodes which are placed, apart from stimulating, they're also able to detect certain brain signals. So especially in Parkinson's disease, there are these certain brain signals which go up when you have your worsening of Parkinson's symptoms. And when you say, for instance, when you go to sleep at night or when you take your medications, those signals come down. So the idea is that by capturing those signals in the brain, can you modulate the stimulation? So when those signals go up, your stimulation goes up so that the signal comes down, and then your motor symptoms or your symptoms improve. And similarly, when you're sleeping or you're not very active, or when your medications are working in your system, and as a result of that, your symptoms are already better, then the system stimulates you at a lower number. So kind of it adapts to the signal. It works very well in some patients. That's why I was talking to you. When I went to share this experience, all of us are very excited about it. The technology is improving, but again, I again say that is I would not put all my eggs in that basket. And I think there are certain patients where it is very helpful, but it's not, the basic principles remain the same. And I don't think the adaptive stimulation is an answer to DBS if the basic principles of DBS programming. It is to refine the existing benefits and treatments, but I just like to kind of have to like to keep an open mind. But I think it's the technology is evolving, and I think it's an interesting era in which we are using more individualized and precision-based stimulation for patients. Another thing is image-guided programming, and Dr. Aronson is actually an expert in image-guided implantation, where he's precisely looking at the structures intraoperatively when he implants these. So it's a good complement to some of his surgical techniques to see how it translates outpatient when we do the programming to use his inputs when he implanted these things. One other thing which I've been kind of one of the things is a remote programming in telehealth. We understand, especially in New England, a lot of folks don't like driving into Boston, and the ability to be able to program and be able to help you remotely is one of the things. There have been different barriers, as we understand, with healthcare in terms of providing that service. But that's another aspect which currently was kind of initially made available through the Abbott company, but now the other companies are looking into. But there has been some barriers to providing care using that. So that's something that we can discuss. Some resources about the DBS that you should look into. Go to reliable sources. There are a lot of different avenues, but I would suggest you kind of look into these resources here to get more accurate information about it. And I think that's kind of what I had to share. And thank you for your attention.
I'm going to introduce Dr. Aronson. Dr. Aronson serves as a functional neurosurgeon and director of epilepsy surgery at Beth Israel Deaconess Medical Center and faculty at Harvard Medical School. He received his undergraduate degree from MIT and his medical degree from Harvard Medical School. He then trained in neurosurgery at Massachusetts General Hospital, including a dedicated fellowship in functional neurosurgery and epilepsy surgery. From 2016 to 2022, he directed the functional neurosurgery and epilepsy surgery programs at Dartmouth Hitchcock Medical Center, introducing several new technologies, including a sleep MRI guided DBS. In November 2022, he rejoined BIDMC with a practice focused on DBS and epilepsy surgery. He also directs a federally funded research lab investigating how neurostimulation changes brain networks and focused on development of the next generation of neuromodulation technologies.
All right. Thank you, Jillian, for the introduction. And I also want to reiterate thank you to our panelists. I think the best way to understand DBS is to really hear from folks who've had it done. They have that firsthand knowledge that they'll share with you. So thank you to Dr. Merchant for introducing the idea of DBS. I'm going to focus more on the surgical aspects. And what I'm talking about is DBS for Parkinson's disease, but everything I say is true for DBS for essential tremor. And I also implant these devices for epilepsy, for obsessive compulsive disorder. I'm leading a clinical trial of DBS for major depressive disorder. The device actually is the same device, and what changes is where we're placing it. And actually not in state. I'm working on a research project where we're going to be potentially implanting DBS for even stroke recovery. So I think this is a technology that has broad applications in the brain, but again, today we're going to focus on how we use it for Parkinson's disease. So I do have some disclosures. I work with a variety of companies, and they provide some research support for various studies. And again, this is all aimed at how can we sort of serve our patients better in the future. We think about surgical options for Parkinson's disease. Historically, there are two options. One is lesion surgery, which is actually destruction of the brain. And this was going on, back in the 1950s and continuing really through the 1990s fairly effectively, where we would destroy a small part of the brain called the thalamus or the globus pallidus with heat or radiation, or nowadays even through ultrasound, which ultimately generates heat. And that can destroy brain tissue. And DBS, on the other hand, is non-destructive, it's reversible, it's adjustable and tunable. And so it's a fully implanted system, so nothing sticks out of the skin. It's fully under the skin, and it can be adjusted over time, and you can actually treat bilaterally. And so, again, just to be very clear on what we're talking about, we have electrodes in the brain, and these are just platinum iridium wires. And they've certainly gotten a little more complicated over the years, but the end of the day, they're basically just wires. And then an extension lead, which comes down the neck, and that's very flexible. So when you move your neck around, it sort of stretches along with you. And then a pulse generator that nowadays we just put one in, and there's two ports, so we can control left and right leads with just one battery. And that's like that pacemaker, as Dr. Merchant mentioned. The other component is a patient controller. So patients are given a device where they can turn the stimulation on or off, or change stimulation parameters within sort of safety barriers that we set. So you have a lot of control over your stimulation if you want it. Some folks really don't want to mess with their systems at all, and that's fine too. But there has really been an evolution here. So, back in the 1930s, Wilder Penfield showed that the brain was electric, and you can use electric stimulation to map function in the brain. And this was explored in the 50s to 70s as a treatment modality for pain, for epilepsy, for a variety of different conditions. But again, this was the era where we were really focusing, before my time in neurosurgery, but focusing on ablations. But in 1987, Alain Benabid, who was a neurosurgeon working in France, he showed that you can use stimulation in an area called the thalamus to treat tremor. And that was approved in the late 90s, first for tremor and then for severe Parkinson's disease. And then we had this era where we saw that this device was effective. And so the approval also changed a little bit. So now it's approved for earlier Parkinson's disease, so 4 years from symptom onset. And then, now that we had these devices that we knew were effective, I think from 2016 onwards, we've had this really tremendous expansion in our technology. So again, the segmented leads, as Dr. Merchant mentioned, abilities to record and remote programming, closed loop. And I think, the overall devices have gotten smaller as well. And I think also, in many ways, more reliable. Like the extension wires are now extremely stretchy, like an old telephone cord, a coiled coil design. So we don't see wires breaking anymore. I mean, this has really become a very reliable technology over the years. So, the first question we come to is, why did DBS replace that ablation surgery? Why is DBS better? Especially now that, some folks hear about focused ultrasound, which is another way of creating an ablation, and wonder, what it makes DBS better. And I think one of the reasons DBS will have took over for ablation surgery is that it could be done bilaterally. So for the most part, bilateral thalamotomy had a very high rate of complications. You can't do these destructions on both sides of the brain. And there are a lot of severe side effects. So in the 90s, we had these papers come out trying to compare the two. There wasn't universal agreement right away that DBS was inherently going to be better. But when they looked sort of head to head, it became very clear that DBS was a better technology, again, because it could be reversed, because it could be tuned, because it could be done bilaterally. And that's still true today, whether you do an ablation in the ways we were doing in the 1950s, or you do an ablation with focused ultrasound. Ultimately, I think for most folks, DBS ends up being the better treatment if someone's a candidate for it. And so when we talk about DBS, we're really focusing on the motor symptoms of Parkinson's disease, which, again, tremor in a lot of patients, but stiffness. And some folks, they experience a lot of walking problems or balance difficulty, slow movements, soft voice. So a lot of these motor components is what we're going to be focusing on. And DBS helps certain ones more than others, which we'll get to in a second. Also, non-motor symptoms, as those living with Parkinson's disease can certainly attest. There can be mood disorders, disruption in sleep, cognitive changes, particularly later in the disease process, and autonomic dysfunction. And so these non-motor symptoms of Parkinson's disease, are important to recognize, and also important to know that DBS does not help with the non-motor symptoms of Parkinson's disease. So again, we talk a lot about patient selection. So if someone comes to me and says, I really feel like my thoughts are foggy, and that's what I really want DBS to help with. And unfortunately, we have to say, well, DBS isn't really going to help with that aspect of Parkinson's disease, unfortunately. But really, we're focusing on the motor symptoms. And folks generally are managed with medications long before I meet a patient often. And over time, folks sometimes develop the dyskinesias, so involuntary movements, sometimes on-off fluctuations. So medications that used to control symptoms for 3 or 4 hours are now, 2 hours, and they're starting to wear off. or medication resistance, where medications used to be more helpful than they are now. And so there's often this sort of honeymoon period where medications are really kind of doing everything you might want them to do. Um, but at some point that period can end and folks develop some of these other symptoms and think, okay, well, maybe it's time to explore options beyond medication. So when we think about DBS effectiveness, which symptoms respond? Again, we're going to really focus on tremor and stiffness, the dyskinesias, those unwanted movements. Sometimes the dystonias like foot cramping and toe curling and motor fluctuations. Those are really the symptoms that we can pretty reliably expect to improve. Some symptoms can be a little bit variable on their response. It really depends on how well they respond to medication. So some patients that have more freezing of gait, well, that's something that often doesn't respond as well. But sometimes walking, particularly if it's responsive to medications, that can be improved. Again, not improved are those autonomic symptoms and cognitive symptoms. So a lot of what we do in our first meetings is think about, what are your goals from Parkinson's disease, from a DBS to treat your Parkinson's disease? And what makes someone a better candidate is, again, I think having a good response to medication and not having issues that might be more risky from a surgical standpoint and more risky from a recovery standpoint. Now, there's two sites in the brain that we look at for Parkinson's disease. So there's the subthalamic nucleus and the globus pallidus interna. And sometimes as folks look into DBS, they sort of wonder, which might be a target. And as I mentioned, the same technology is used for other diseases. Again, different targets in the brain. For essential tremor, we target this area of the thalamus called the VIM. And so in the case of Parkinson's disease, we have two targets that we use, and meetings years ago, we used to have discussions about which is the better target. Now we know that there's reasons why we might prefer one target over another, depending on the individual patient. So, for example, we think about the subthalamic nucleus in patients who have a severe tremor or if they have significant medication fluctuation. Sometimes we want to reduce medications because of side effects. In STN, we see a better medication reduction. Whereas the globus pallidus, we often will target the globus pallidus for dystonia or severe dyskinesias, or if someone has some underlying mild cognitive or psychiatric issues, we'll target the globus pallidus. But at the end of the day, they're both good targets, and I think it's worth a discussion about your individual needs from DBS. So I always encourage folks to come and meet me pretty early on. And as we talked about, DBS is approved 4 years from symptom onset, but that doesn't mean you have to wait 4 years to see a neurosurgeon. I think it's very difficult to know, at what point you might be ready for DBS. If you haven't really met with a surgeon to know, what it is. So I encourage an early visit. And I've had patients come in and say, I'm not ready for this, but I wanted to hear more about it. And so at that first meeting, we'll discuss your symptoms, your response to medication, how that has changed over time. We'll talk about what your goals are. I've had patients say, my goal is really, to get a certain amount of activity back or be able to do a certain activity. For some folks, that is, a hobby that they miss doing and want to really be able to do again, improve their golf game. We'll talk about your medical history. So, what medical problems do you have and what can we do to optimize those medical issues before surgery? There's not a particular uh, aspect of medical history that would bar you from surgery. So, folks who've had, heart surgeries, transplant surgeries, I mean, all of the above I have operated on safely. But I think it's important to optimize whatever testing we need before surgery to make sure that we make the surgery as event-free as possible. And then we'll talk a little bit about your cognitive function and any psychiatric symptoms. There are the two tests that Dr. Merchant had mentioned as well. So there's the off-on testing, which typically would be done by a neurologist. And again, this is evaluating your response to medication. So again, patients who respond well to cinema. Now, of course, that's understanding that that response is not as good as it used to be, or is not as complete as it used to be, or doesn't last as long as it used to be, all completely understandable. And that's, probably why, someone might be coming in to think about surgery. But again, evaluating um, evaluating the response to medication is really important. And then there's a bit of a similar evaluation that we look at for tremor as well, for essential tremor. The other is the neuropsychological testing, which again, we get in everybody who's coming up for DBS. And that's actually true for Parkinson's disease, true in my epilepsy patients as well. And this is really just understanding what your level of cognitive function is that might prove a barrier or a challenge to recovery. And also to make sure that there's nothing unexpected from the cognitive aspect that maybe pushes us to think maybe this is not Parkinson's disease, but a Parkinson's plus syndrome. And so, I'm never really surprised by these assessments. I think sometimes folks get nervous, like this is, some sort of, like college exam or high school exam or something that you have to sort of study for or be ready for. I think folks generally know, how they're doing just from my meeting with them. But it's going to be a fairly significant battery of tests of attention, language, function, um, screening for any mood, anxiety, or social factors that might, again, be a challenge for recovery. And so if someone asks me who's the ideal DBS candidate, again, not everyone with Parkinson's disease is a candidate for DBS. So I think a clear Parkinson's disease diagnosis, so nothing atypical. And that's something that your neurologist would be able to evaluate. A good medication response. So if you had a good response to Cinemet, again, understanding that Cinemet, carbidopa, levodopa is not lasting as long or is not as effective as it used to be. But again, having that good medication response in your history is a positive prediction. Good cognitive function doesn't mean that you feel like as sharp as you did 10 or 20 years ago, but good cognitive function to participate in the recovery process. And then again, realistic expectations. So we think about your best response to medication would be your best response to DBS. Again, hopefully that best response is more of the day, longer during the day. And the exception to that is tremor, which again, we see a bigger improvement for tremor than we do for medication. So medications treat tremor and Parkinson's disease, but DBS treats tremor a little bit better. So traditionally, and when I say traditionally, I mean including, when I was training at Mass General, we did all DBS surgery awake. And the reason we did it awake is because we would start with an MRI, your MRI, and then based on the MRI, we would have a standard measurement that was determined by an atlas that was created decades ago off of autopsy specimens. And we would say, okay, well, we take the center spot of the brain, we adjust in a standard way. That's going to be our target, but we need to make sure that your brain is close enough to the atlas that we're using, and so we'd have to have you awake to do some testing during surgery, because when we talk about accuracy of DBS, we need to be accurate to within 2 millimeters, so not close enough. It has to be really spot on accuracy. And so, awake surgery, if you've ever seen YouTube videos, sometimes there's these really dramatic videos of like, someone playing the violin during surgery. That's where that comes from. And, makes for dramatic videos to have folks awake, but having a frame on your head like this during surgery where you're bolted to the table, it's unfortunately, as uncomfortable as it looks. And so we had a variety of ways of trying to get away from this. When I first got to Dartmouth, we moved to a robotic system with patients awake. But the reality is that being awake during surgery for about 4 hours while someone's doing brain surgery really is not very comfortable. And so as of 2025, I think, we really don't need to be doing this with you awake anymore. And I'm going to get into why that is. So a sleep DBS, so this is under general anesthesia. I think this is a significant advance. And I'd say, slowly the world of functional neurosurgery is coming around to this. But I'll say, I was suspicious of this when I first heard it because, again, we trained all of us in this era of awake DBS surgery. But what changed my mind is looking at the outcomes. And the reason why we can do a sleep surgery today for DBS and we couldn't in the late 90s is because of the MRI sequences. So now, instead of relying on a basic MRI and standard coordinates that were based on autopsy specimens of someone else's brain, now I can look at the patient's own brain. So the person in front of me, I look at their brain and see on that MRI where I want to place my electrode. Okay, so we call that patient-specific targeting. So based on your own anatomy. And in essential tremor, we also bring in some connectivity maps. So the brain has certain white matter tracks, the wires of the brain, and we can use that to target for essential tremor. And we also use real-time imaging in the operating room. So we can use an intraoperative CT or MRI to make sure that not only are we targeting based on your own MRI, but we're actually placing the electrode where we intend to place it exactly. That means that we can do a combined procedure. So it used to be that we would place the electrodes in the brain, and then a week later, we would funnel the extensions and put the battery in. And we would do it staged because putting the wires in the brain, you had to be awake. And the whole rest of the surgery, we would want folks asleep. And so we would do this staged as two surgeries. Because I do the first surgery with folks asleep, I combine both into one single surgery that takes about 4 hours. And then folks generally stay one night in the hospital for monitoring. And so to get into this a little more, so this is someone's MRI that I planned a DBS trajectory on. And so you can see our target is down here. I don't know if you can see my mouse, but it's that bottom sort of circled area at the bottom of the orange DBS trajectory. And so these are, all shades of gray. All MRIs are shades of gray. But I couldn't tell you that that's the spot and 2 millimeters over is not the spot. It's all the same shade of gray. And that was really our challenge. And that's why you had to be awake. But for example, in 2025, we have new MRI sequences like quantitative susceptibility mapping. And so now we can see that bright white spot these arrows are pointing to on the right side of the screen. Now we can see our target. Okay, and I'm going to zoom in a little more there. We can see the subthalamic nucleus, or STN, distinct from other structures around it. So now I can look at someone's MRI and see exactly where I want to put the electrode. And so I don't need folks awake to give me that feedback because I can target based on the actual MRI visualization. And so that makes for a very big difference. And so what convinced me that this is something that we should explore? So the early data came out of places like UCSF, which is a pioneer in doing this. And so they show that their outcomes were equivalent. And now I started doing a sleep DBS almost exclusively about 6 years ago. And so I'd say I was, on the early side of adopting, but now this has become, more common, and several groups have published their results. So these are several papers from 2025, but there's papers, going back many years now, and I've looked at my own data from the time before I started doing the surgeries asleep to now when I'm doing them all asleep, and we're not better, we're equally good. Okay. And I think that that's the important take home point, is that there's no benefit to being awake. I think it's more comfortable to be asleep. And I think being asleep means that, we can again do all of the surgery in one setting. And it's just a lot more comfortable. And I think in some ways, I'd say we are a little bit better because, say, when I was doing the surgeries with folks awake, we do one side and we do the second side. And by hour 3, folks would get a little bit tired of being awake, kind of tethered to the bed in this whole apparatus. And so we have to sort of speed up on the second side. Now with folks asleep, we take as long as we take. We can close really carefully. We never feel rushed. So I think overall, this is, I think, better for patients and better for the whole surgery. So I would say as of 2025, we see that DBS is, I think, safer than it has been in earlier generations. The hardware itself is better. I think the complication rates are lower. I think that, overall, the decision to undergo DBS is very, very much individual. I think it depends on your disease progression, what medications you've tried, what you haven't tried, what the impact is on your quality of life, and what your goals are, what your preferences are. And the procedures, there are surgeons who do the surgery still awake, and folks like myself who do it all asleep. I think, they're both options, but there's really equivalent outcomes. So there's no advantage to being awake. And I think, again, there's a lot more comfort to being asleep. And again, it's that direct targeting capability. And I think these are only getting better and better. And how we're doing this is getting better and better. I think, again, for tremor, we're publishing our results of using what's called tractography, those wires of the brain for essential tremor, which is, think still not widely adopted, but I think gives us a very safe and effective way of doing DBS for essential tremor safely asleep. So we don't need to have this historical dependence on old atlases. Okay. And with that, I'll stop and I'm happy to take any questions. Yeah. So I guess one of the frequently asked questions I get is, how do I know if I'm too early? What if I get it too early? Will I run through my benefit of DBS? And I think basically, DBS continues to work, but the disease is progressive. It is not a cure. And so over time, just like you might take more medication, we might change the DBS programming, but there's not a sort of too early that you're going to run through the benefit. It will continue to have benefit as you age and go through different stages. I do see some Q&A as well, which maybe I'll just answer two of these. So the head frame, it can be attached when you're asleep. So depends on exactly the technology the surgeon is using. So the way I do it at Beth Israel, nothing is done with you awake. So once you're fully asleep, then we put on the head frame. And if I do the surgery robotically, again, we have to have your head held somehow. So we would do that once you're asleep and removed again before you wake up. And then the other question is what hardware is usually used. So there's 3 companies in the US that are approved to market DBS devices specifically, and that's Medtronic, which was the original, Abbott, and Boston Scientific. They all basically work the same way. They put electricity into the brain. There's some nuance between them, but all of them I think are very reliable. And that's a discussion that I think, the exact particulars, like for example, like when I was practicing at Dartmouth, if you live very far away from your neurologist, maybe the remote programming of Abbott would be very appealing. But I think exactly which company device you might prefer is a good discussion to have with your team.
So yeah, just to add to Josh's thing, I think yeah, the devices are helpful. They have the nuances, and I think some of the discussions about the devices we have in terms of whether you want the rechargeability again, that's not a big difference between the two. There are certain disorders and certain scenarios where you prefer to have the adaptability if you have a lot of fluctuations in your symptoms. And I have found it the recording of the signal is helpful for tremor. If tremor is a major problem in my practice, when I'm kind of looking at this patient's long term, I find the intuitive programming I talked about, right? The directionality and how intuitively you can do that, that ends up being an important factor. So it all depends on the goal of the surgery and actually the major symptom, and again your inputs in terms of what is important to you in terms of the quality of life, whether you prefer to have a rechargeable system. Most of the, if you're much younger, you prefer to have a longevity of symptoms. But those are some of the discussions that are, so there is kind of device agnostic in some ways. I think we need to make sure that you are comfortable with the choice of device that we talk, and the indication for choosing that brand is important. I was looking at another question about why are certain PD docs more hesitant to recommend DBS. That is true, and I think it's it's kind of comes to the point about a lot of the folks are hesitant because a lot of them don't practice this treatment. Unfortunately, a lot of as you will go around in the field of movement disorders, a lot of the more very senior folks who have been around for a long period of time, they're trained and they are used to treatments which are mainly pharmacology based, and they don't know better. So unfortunately ends up being you kind of go into the same cycle of more medications and more things, which again, in my opinion, having kind of finding the middle of the two approaches, having trained with both sides of things, as I say, it's important to introduce the treatment at the right time. And there are these old school, when it was initially done, was in patients who are much more severe when the medications were not that. And now the experience for DBS is over 30 years, and now we know much better that introducing it early when needed and appropriate is important. So there is hesitancy. A lot of it goes to in terms of what you're comfortable with, whether you are an expert in treatment, what experience level you have. That's kind of the thing. I think I'm going to answer one more question, Josh, and then I will have you answer the robotic question about the robots. So your question about, it's an interesting question. Does DBS equate to best medical outcome? And the second part of that question is, does DBS revert to best medical outcome prior to wearing off? Uh, to first question, I'm gonna, because different disorders is different. So for instance, for tremor disorders, the DBS outcome is much more superior because patients who do not respond to medications, they respond to the surgery with essential tremor. So especially when the tremor is severe, patients are not, there is no response to medication. So DBS outcome in that case is better. Similarly, for tremor dominant Parkinson's, where your tremor is unresponsive to medication, that's another indication where the response is superior. Now, coming to the question of in Parkinson's disease, the response to slowness of movement and mobility problem and rigidity. And the other issue which goes with that is the fluctuations, that the dependence on the medication, which is causing you to take the medication every 2 hours, every 3 hours. So what the DBS is allowing you to do is to make that more even keel. So it's not about the best outcome or the best benefit. It's about coming to a level where it is the benefit is optimal. At the same time, it is your quality of life is improved to a certain extent. So as far as the effects, it's we can say that the combination of medicine and the DBS is what leads to an optimal outcome. So I would not want to put it as if DBS versus medicines. There are certain benefits of taking the medicines in Parkinson's disease, that the dopamine has an effect not just on your motor symptoms, but your behavior, the way you act, how you respond to symptoms, and then the motor symptoms. So what DBS allows you to do is to come down on the medication dependence, at the same time fill that benefit with the DBS or the stimulation therapy. So it allows you to experience a benefit which is a combination of the two, and optimally combining them. Most, if not all, our patients after DBS feel better than they did just on the medications, and even when they were optimally treated at the medication doses they were. So that's kind of what my experience has been. And Josh, I think the question about robotics, I'll defer it to your expertise.
Yeah. So, is robotic surgery used for better outcomes? So, I think robots sound cool, and I do use a robot in surgery. And I remember being in a meeting once with Medtronic, and they said, how important is it that the robot, improve outcomes? And I remember one of the other neurosurgeons there said, well, robots are cool, so I think people will just want to come for the robot. And my response was, well, we have to be good stewards of healthcare dollars. So just doing something because it's cool and buying a multi-million-dollar robot, I think it has to show that it's actually creating a better outcome, not just well, it's 2025, let's use robots. So I think the what changes outcome, I think, or changes the patient experience is doing it asleep or awake. I think how it's actually done doesn't really depend on the robot. And I think I did use a robot which made it more comfortable, but that's because the robot was mounted to the skull, and so you could move your head around during surgery as opposed to being sort of fixed in place. I think it's a question of like exactly depending on who you're seeing as a surgeon, what is the robot really doing for you, or doing for the patient and doing for the surgeon. So I think the way that most robots are, they're not as accurate as traditional frame systems. So I'm a little hesitant to recommend sort of robotics off the bat. I think the traditional frames are I think a great option. I just think that it's not the easiest patient experience. So that's why again, doing it asleep can be better. But I think robots are very good at doing multiple times doing the same thing without making an error. And so like I use a robot for a different surgery. I'm placing 12 to 14 electrodes in the brain for seizure monitoring. And so they're programming a frame 14 times, there might be an error, but a robot will not make an error. So I think if you're seeing a surgeon, they're talking about robotic surgery, I think just ask a lot about, how does that change what they do and what your experience is.
Uh, One question which I notice here, it's a good question. This is a very typical scenario about asking about you are someone who is taking medications every 3 hours, about 6 times a day. and am I the right candidate? So, so again, it depends it depends on the nuance of the question. I would not want to proceed directly to doing the surgery. There are medications which can act longer. We can give you medications to help supplement some of the effects of the medication, but it also depends to as to what is the motivation for you to take the medication every 3 hours. And when you take the medication, are you, what is the degree of benefit you get and how satisfied are you? And if you're having side effects, even when you take those medications at the best effect. So those are all nuances. So I cannot tell you just on the basis, the number of doses of medications you take itself is not the reason I would want to pursue surgery. But you are, unfortunately, I would say the trend, what you are having is that requirement for the medication is increasing, the effects are wearing off quickly. You have to define as to what is the reason, what does that dopamine medication do for you? And that's where the answer lies. So, but I would definitely encourage you to pursue that conversation and get a more get your questions asked and get evaluated by someone who does this and a center which is experienced. And we are, of course, happy to answer those questions and see you in consultation.
I just want to reiterate one thing that Dr. Merton said is that, again, we're happy to talk to you about your particular situation one-on-one, and it doesn't commit you to being down, going down this road of having surgery. I think it's perfectly fine to see, one of us and just say, look, I don't think I'm interested in surgery, but I need to learn more about it in my particular situation. Because again, the experience of Parkinson's really, every person is different and how they're experiencing it and what their goals are. So